Thank you very much, Luis. Friends, colleagues, good morning, buenos dias, bonjour. I want to thank the conference organizers for inviting me to speak to you this morning. I have attended many of these conferences, but like you, I remember Durban 2000 as a turning point in the epidemic. How far have we come since then? My hope is that Durban 2016 is also a game changer, and that we'll leave here energized to finish the job begun 16 years ago, because I really don't want to come back in 16 years. These are my disclosures, which are none. So when I first was assigned this title, what's new, what's next, what's ahead, I thought a lot about how daunting this was. The what's new was cleared by the International AIDS Conference when I picked up my badge and said that I was from the Sarawani Republic. I had no idea where this was, so what was next was for me to Google what this was. And what's ahead? Well, that may be the place I need to go after Donald Trump gets elected president, which I sure hope doesn't happen. Well, enough of that. In the past 5 years, we've had unprecedented breakthroughs in research on HIV prevention and treatment. And many of us are confident that if we implement what we know works, we will end the epidemic. But that is exactly the issue. Implementation has been the challenge, and implementing the research findings into policy and practice has been very slow, and in fact, that inertia has been deadly. Therefore, we must know what is new to inform decision makers on what needs to be implemented. Because the reality, my friends, is this is the best of times. As we've heard many times during this conference, over 17 million people are on therapy. Just think about this. When we met in 2000 here, around 10,000 people in the entire sub-Saharan Africa were on antiretroviral therapy. Today, more than 12 million people are antiretroviral therapy in sub-Saharan Africa. This has been the most successful and ambitious public health program ever implemented, and for that, we should be proud of. As a result of that, AIDS deaths have declined by 45%, AIDS incidence has declined by 35%. We know treatment is prevention, we know treatment is indicated for everyone infected, and we know that pre-exposure prophylaxis works. This past Monday, in the New England Journal of Medicine, they published the final results of HPTN-052. There's a dramatic decrease in 93% in infected individuals after 5 years. So the impact of the intervention has been sustained over a long time. In addition to that, this past week also, JAMA published the results of the partner study that finds incredible results as well. There were 0 link transmissions among serodiscordant couples having condomless sex when the HIV-infected partner was in antiretroviral therapy and virologically suppressed, irregardless of the type of partnership, heterosexual or MSM. Clearly, this is why antiretroviral drugs have become the cornerstone of our response to the public health approach we have taken to HIV. And this has helped blur the divide between prevention and care that sometimes has impacted the way we react. However, we need to do things a lot more quickly. I hope you leave this meeting with a sense of urgency that we have to fast-track our response to AIDS, because business as usual is not only stalling the gains we have made, but may actually be leading to more rapid increases in new infections and AIDS deaths. So what's next? Well, first of all is the sub-Saharan youth bulge that is happening, and it cannot be ignored, because the gains we have made in life expectancy through provision of antiretroviral therapy, vaccination programs, and maternal-infant health programs have more than doubled the number of, more than ever, people are entering sexually active years in sub-Saharan Africa. And we have to ensure prevention gets to the majority of them. If we don't, the same rate of new infection is going to produce more people being infected. In addition, the number of adolescents in antiretroviral therapy has increased, but the challenge of adherence and virological suppression in adolescents remain there. In this abstract presented at this meeting, you can see the types of virological suppressors that was being obtained in adolescents. We need adolescent-focused programs, we need long-acting agents, and we need better approach to therapy for adolescents. My friends, the next decade of AIDS is going to look very much like the first decade of the epidemic, with gay men being most at risk. The data recently published in Lancet by Chris Bayer and his colleagues shows that we have ignored men who have sex with men in most of the world for much too long, and this has been a costly mistake. A related challenge, for example, is in the United States, where the epidemic increasingly affects populations that historically have suffered health disparities, the poor and racial ethnic minorities. While HIV risk for men who have sex with men is higher than in the general population, the risk of acquiring HIV for a white MSM is 1 in 11, while the risk is 1 in 4 in Hispanics and 1 in 2 in black MSMs. Let me repeat that, 1 in 2 in black MSMs. This is simply unacceptable. Where is the urgency? We have had PrEP approved in the United States since July of 2012, yet the number of people prescribed PrEP has been pitifully small, and most have been white MSMs. So PrEP has the potential to actually increase even further the racial disparities we see in this slide. Why has it been so hard to scale up PrEP? Where's the outrage? What are we doing about it? There's no doubt that we need better approaches to biomedical prevention. The sobering results of FemPrep and Voice and the modest efficacy of the dolutegravir rings, mostly due to poor adherence, primarily among the youth, are clear examples that we need better approaches. There are, in fact, many things in the horizon. Long-acting injectables being studied in HPTN 083 and 084, the infusion of broadly neutralizing antibodies being tested in HPTN 081 and 085, and the launching of HVTN 702 that was announced at this meeting by Linda Gelbecker, building on the results of RV144, the only HIV vaccine that has shown any positive results. And in fact, I hope that in the future, we're not asking the question, do you want PrEP? But we'll be asking people, how would you like your PrEP? Yet we cannot await for the results of the studies, and it's urgent that we scale up PrEP now. Many infections could be averted if we do this immediately. We also need better treatments. In most of the world today, efavirenz-based regimens are the most commonly prescribed, yet in most of the developed world, integrase inhibitors are now increasingly being used as initial therapy. This is creating, as you heard before, a double standard, and we should not accept it. What is considered best for an American, a European, or an Australian should be the best for everyone in Africa, Asia, Latin America, or the Caribbean. Cost is an issue, but studies are being conducted with dolutegravir in combination of TAF, FTC, and tenofovir, FTC, that will undoubtedly inform WHO guidelines in the near future, and the possibility of a generic and affordable combination of these drugs in low and income countries will clearly be a game changer. In the meantime, we need better access to second and third line drugs, and we need to scale up viral load testing if we are to measure the final 90. With the upfront disclosure that I'm part of the panel that wrote these guidelines, the International Antiviral Society USA published updated guidelines in the treatment and prevention of HIV this week in JAMA. These guidelines again blur the chiasm between care and prevention approach and approach it as a continuum, and for the first time include integrase inhibitors as the preferred drugs for the initial therapy for HIV. These guidelines also no longer recommend MAC prophylaxis for those with CD4 count less than 50 that are starting antiretroviral therapy, and CD4 count monitoring is not recommended for patients who are virologically suppressed and have a CD4 count consistently above 500. But the big question we ask ourselves is, can we treat our way out of the epidemic? At her opening plenary the first day, Stephanie Strathy clearly told us no. And it's not because it is not scientifically or theoretically possible to do this, but it's of the enormous challenges ahead. The biggest of them is weak healthcare systems. In his opening plenary, Alex Coutinho warned us about premature declaration of victory, what I called the George Bush mission accomplished syndrome. But also, we have not paid enough attention to healthcare systems, and we need to strengthen them if we are to end AIDS. Because we're really not doing this that well. In the United States, for example, only 30% of HIV-infected persons are virologically suppressed. And even more worrisome, 50% of them are not engaged in care. Because retention in care, and particularly long-term retention in care, is now one of the major challenges we face for ending AIDS. And to illustrate that this is not just a problem with HIV, I'll show you here the cascade of care for diabetes in the United States. As you can see, the number of people that have a hemoglobin A1C less than 7.5 and control of their blood pressure is also very small. Can you imagine what the community glucose load actually is in the United States? Pretty high. What does this mean? Well, it means that what we do in research to improve the care continuum of HIV will have immediate applicability to the care of non-communicable diseases like diabetes, hypertension, or heart disease, which are now major causes of morbidity and mortality globally. What are then the major barriers for optimal outcomes? Well, there are basically four. too little and too late HIV testing, suboptimal linkage to care for those who are found to be positive, dismal retention in care, and poor adherence to antiretroviral therapy. In my opinion, we know and we've done a lot of things to increase HIV testing. We have improved linkage to care, we've improved adherence, but retention in care is now the Achilles heel of HIV Care Continuum, and we know precious little about how to make it better. Poor retention in care is a key challenge for reaching the last 90 and has enormous public health implications. Here you can see data from a recently published study by Jacek Skarbinski from CDC using data from the Medical Monitoring Project that suggests that most HIV transmission in the United States is now happening from people not engaged in care. Therefore, if we do not improve engagement in care, we're not going to be able to stop transmission of HIV. And let me remind you that this is not just an American aberrancy. Throughout the world, retention in care is bad, and in particular long-term retention in care. As you can see in this slide, less than 50% of people with HIV are retaining care after 5 years. As you've heard in this meeting, differentiated care may be a patient-friendly way to get into a better retention. Not much research has been done to understand why people disengage from care, but I want to point your attention to the study by Norma Ware and colleagues, in which they talk about a two-hit hypothesis, where either an unintentional or an intentional reason to miss an appointment is followed by reluctance to return to care, a weakened sense of connection in care, and finally disengagement in care. This is a list by no means comprehensive of some of the strategies that have been tried so far to improve the care continuum: case management, peer navigation, financial incentives, home self-testing, and differentiated care. Patient navigators were developed in 1990 by Harold Freeman, who joined forces with the American Cancer Society as an approach to improving breast care outcomes among Black women in Harlem. The primary goal of Patient Navigator was to assist patients move through the entire system of medical care. This intervention proved to be effective and improve outcomes for those women. What do Patient Navigators do? Well, they coordinate treatment care, they provide health education, they assist patients in overcoming personal barriers, and they provide psychological and emotional support. What do we know about patient navigation in HIV care? There are unfortunately very little data to support this intervention, and particularly almost no data that uses viral suppression as the outcome. In the study by Judy Bradford, reduction in barriers to care improved health outcomes. And we heard at this meeting from the HPTN-073 study that care coordination improved uptake of PrEP among Black MSMs in the United States. Contingency management is another strategy which involves the systematic reinforcement of desired behaviors through financial incentives. This has been proven to be effective in alcohol and substance abuse disorders. What do we know about contingency management in HIV care? Again, not much. In HPTN-065, Wafa El-Sadr and colleagues found that financial incentives did not increase linkage to care or virologic suppression, except at sites where there were low suppression rates to begin with, and it did increase continuity of care by only 8%. I have a confession to make. I have always enjoyed hard challenges. I like to swim in rough waters and go where the mess is. This is where the action is. This is where you can make a difference. And so the so-called hard-to-reach populations is where the true reservoir of HIV is. As researchers, as clinicians, as advocates, I would encourage you to work more to make sure these populations are not left behind. Because many times I feel like when people talk about hard-to-reach populations, it's simply an excuse for not trying to reach them. In this week in JAMA, we published results from a NIDA Clinical Trials Network 049 study in which we tested the randomized clinical trial using patient navigation with or without financial incentives to improve viral suppression among particularly difficult to engage populations, HIV-infected substance users. During the 6 months of the intervention, virologic suppression in the patient navigation plus financial incentives improved. But 6 months after the intervention stopped, the benefits wore off. And at the end of 12 months, there was no differences between the groups, with approximately 30% of the patients being virologically suppressed at the end. So is contingency management dead as a strategy? I don't think so. In a pilot study we recently conducted in collaboration with colleagues at the National Bureau of Economic Research, financial incentives coupled with individual choice led to increased ART adherence and viral suppression that persisted when the incentives were removed. And I want to emphasize, is the financial incentives coupled with individual choice. My take on this is we need to better understand behavioral economics to take full advantage of this strategy. Home-based testing is another potential strategy that may be useful in improving access to care. You have heard enough about differentiated care at this meeting. The latest WHO guidelines make it very clear that this is a way, again, that we can improve retention in virologic suppression. Other novel strategies include couple counseling and testing, taking the healthcare facility to the people, like Linda Gale Becker has done with Tutu Tester, and multi-disease streamlined care, as well as rapid start of ART. Couples counseling and testing is a strategy that has been useful to help couples mutually disclose their HIV status, adopt behaviors, and help them protect their partner. This strategy was developed by my colleague Susan Allen in Rwanda, and it has been adapted to MSMs by Patrick Sullivan and Rob Stevenson. Multi-disease streamlined care has been done by Diane Havler and her colleagues in the SEARCH study, and this is also an innovative approach. Again, SEARCH is about taking HIV care and prevention into a different level and talking about HIV, malaria, diabetes, hypertension, and other chronic diseases as integrated care. At this meeting, we saw the results of SEARCH, and they are indeed impressive, exceeding the 90-90-90 after 2 years of follow-up in rural communities in Kenya and Uganda. The lesson for me is clear. Stop thinking of vertical problems, to start thinking about integrated care for chronic conditions that are increasingly prevalent in communities we're engaged in. Rapid entry into care and immediate ART is also a novel strategy. In San Francisco, the time from clinic referral to patients achieving viral load less than 200 has been compared between Rapid Start, Universal ART, and CD4 guided care. And as you can see, Rapid Start made a big difference. Similar findings were made here in South Africa, where the Rapid trial again showed very rapid initiation led to better retention and virologic suppression. We have ignored clinical laboratory infrastructure for far too long in the developing world. In HIV, we have been able to place flow cytometers to measure CD4 counts in many hospitals and clinics, but at those same hospitals and clinics, the capacity to do simple tests like a blood count, serum chemistry, or diagnose tuberculosis is simply not there. It is time for WHO to develop an essential diagnostic test similar to essential medicines and make sure that we have access and patients have access to them in most of the world. In the meantime, we need to scale up viral load testing if we're going to be able to measure the third 90. Many equipments are in the pipeline, and then hopefully in the future, a point-of-care technology will be available. So what's ahead? Well, this is also the worst of times. 17 million people is only 63% of the estimated 27 million we need to reach for the second 90. There's flat funding for HIV. We have transition from MDGs to SDGs. Stigma and discrimination persist. There's little attention paid to tuberculosis, and there's lack of harm reduction and substance abuse treatment in most of the world. Declines in new infections have stalled and are rising in some regions. As you can see here, in many places we have seen an increase or a flat in the new infections. And let's just don't forget that 1.9 million new infections per year is still an unacceptably high number, and we cannot be complacent with that. Flat funding from PEPFAR is also another problem. And even though there's flat funding, you can see that, in fact, if you look at the number of dollars available from 2010 to 2016, this, if you adjust for inflation, is actually a decrease. So in reality, there's a funding gap of about $7 billion that we need to fill. And this is why we need to demand that the Global Fund be fully funded. Not doing so not only will impede us from reaching 90-90-90, but also will lead to further increases in new infections, a reversal of the gains made thus far, and at the end, a much more expensive response in the future. Because like Dolly Parton said, you have no idea how expensive it is to look this cheap. The end of the Millennium Developmental Goals in 2015, if you remember, there were 8 priorities, with HIV/AIDS being specifically mentioned as goal number 6. Well, now we're in the area of the SDGs, where we have 17 priorities, and where HIV is not even mentioned. It's kind of buried in this goal number 3 of good health and well-being. And if you know anything about decision makers and politicians, allocating resources is all about being inside. Not inside is not in mind. We're not going to be able, people think that HIV is gone because it's no longer mentioned as a priority. I don't need to remind this audience that stigma has to end. If we don't, the epidemic will continue. If we don't make zero stigma and zero discrimination a reality, we will not end AIDS. Tuberculosis has also been ignored, and as you heard at this meeting, we will not fight AIDS, we will not end AIDS unless we do more to fight tuberculosis. What are we as an HIV community waiting for? We have got to advocate for funding for TB programs as a necessity. It is critical that we do this if we're going to end AIDS. Finally, globally, there's poor access to substance abuse treatment, including carbon reduction, and this has fueled HIV transmission. We need comprehensive and integrated substance abuse treatment within HIV now. Because I hope I convince you by now that HIV and AIDS are not simply a viral infection. AIDS is actually a disease at the confluence of infectious diseases like tuberculosis, mental health illness, substance abuse, and poverty. And thus, if we're serious about ending AIDS, we have to have a holistic approach to the pandemic. We have to build on political will, as this is paramount. Last month's high-level meeting on AIDS at the United Nations is a good starting point, but we need to build upon the meeting in Durban as well. So I will end by a call for action. As many of those that know me know, I'm a clinician, and therefore I want to ask my friends and colleagues, clinicians, 4 things. Number 1, we need to do a better job doing what we already know. We need to test more, link, retain, and provide adherence support. We need to provide PrEP and combination prevention now. We need to be part of the movement to re-engineer the healthcare system. Prevention and care are a continuum. We have to work with our testing sites. We need to be advocates for human rights of those at risk and living with HIV. Zero discrimination will be needed before we have 0 cases. And finally, we have to retake our role as activists and help better communicate that HIV is still a major health problem globally. Because, my friends, I would ask you to be passionate, be angry, and don't accept the status quo. Thank you very much.